Cataract surgery is one of the most predictable procedures in ophthalmology. Until you're faced with a rock-hard Brunescent lens in a patient in their 90s. These cases demand more than a routine technique. They call for a careful planning, the right tools and very steady hands. I'm Dr. Koen Willekens, and in this independent medical education case review, I'll show you how I managed a dense Brunescent nuclear cataract using the QUATERA 700. We'll look at how I adjusted visco handling, optimized my phaco settings, divided the lens with the mile loop and applied an posterior chopping technique to bring the surgery to a safe and successful conclusion. This is a patient in their 90s, actually 93 years old, female patient, suffering from a severe cataract. So she had a vision on her worst eye, the right eye, of 0.1, but with a little bit help. Optimized refraction, and on her better eye 0.3. So with an axial length of 22.17 millimeters, we were left with an anterior chamber of 2.3 millimeters, which is significantly shallower than we are used to in a regular Phaco case. We took a close look at her endothelial function, which was luckily still good. In this very dense Brunescent cataract, the nucleus becomes terribly hard, like a rock, and so we need to get the rock out. We try to limit the intraocular pressure during the surgery to maintain the best ocular perfusion possible during this case under topical anesthesia. So we had a preset of 30 millimeters of mercury in every step of the cataract surgery. So during phacoemulsification, but also during irrigation aspiration steps. I work usually with quite a high vacuum to ensure that you have a swift surgery and efficient surgery. And because of the high vacuum, I try to limit the amount of phaco energy that is needed to suck in lens pieces. And we will start with the beginning by dilating the pupil using midrain, which also anesthetizes the pupil of the iris, of the patient a little bit. And then you see the first step of injecting a little bit of a very cohesive viscoelastic in the middle of the eye. Just you have some sort of bleb in the middle, but you still have fluid around. If you would fill the anterior chamber in the beginning with a very dispersive viscoelastic material, then it's more difficult to rinse it all out at the end, and it might block your trabecular meshwork. And to avoid too much stress on the zonulae and to avoid too much expenditure of phaco energy, we use the mile loop from Zeiss to do a dividing step prior before using the phaco handpiece. In order to use the mile loop, you need to create a bit of space for the mile loop, so you need a very good hydrodissection first of the lens from the capsular bag. That's one thing. And then I take a second step for a viscodissection, so where we put some dispersive viscoelastic in between the lens and the capsular bag. Then we slide the mile loop in. We slowly expand it while shifting it around the lens. And then you need to be able to turn a little bit, and you see the shadow of the mile loop going behind the lens, but at 5-6 millimeters behind the plane that you're actually looking at. So you see the shadow moving. Once you're sure that it is freely moving and you're in the middle of the lens, you tighten it, and then it slices through like someone would cut a marble stone actually. Normally, people that are chopping are using a chopper, which is an instrument with usually very sharp. Usually they place it in the lens and they rip the lens apart piece by piece. I don't like a very sharp instrument inside the anterior chamber, especially if you're not really sure about how the eye will behave. So what I use is a blunt instrument. And this blunt instrument, I can touch the capsule without any problem. It won't rip it or tear it. And I can use it to push from backwards in the direction of my phaco handpiece. So instead of moving on top and pulling it away, I'm just moving back and pushing with the phaco. So I crush the lens in between the two instruments that I have. And this way I don't exert any tension on the zonulae. And I am sure that I'm away from the capsular bag. It was quite swift. I believe in total it took about 10 minutes. Usually a standard Phaco case is a bit faster, of course. And operating on a 93-year-old patient under topical anesthesia, it's also meant to be swift, because you can't expect of a very elderly person to lie still on their back for 20, 25 or even longer minutes. So it's important to be efficient and quick. I was very happy with the surgery, and very happy when we finally got a nice cleaned capsular bag where we could put in our IOL of choice. Day one, post-operative, there was a little bit of a pressure spike up until 20 millimeters of mercury, but not that high, and still a little bit of swelling of the cornea. But 2 weeks after the surgery, she obtained a visual acuity on the right eye of 0.8, so we were extremely happy. You need to follow up these patients very strictly. I would suggest, at least in these cases, you marry your patient for the first weeks after the surgery. So you see them back quite a lot to reassure them, to reassure yourself, and to avoid any medical legal problems afterwards. And in respect of lowering the pain level of the patient, it's the eye pressure during the surgery and the pressure spikes which need to be managed, and applying a sting like the MyLoop, adjusting your settings, optimizing your chopping technique, making sure that every step is as safe as possible. In the end, all of these small things will add up to a better feeling, a more confident surgeon, and a better surgery and surgical outcome in the end. Thank you for watching this episode of the ESCRS Independent Medical Education Phaco Complex Case video series. Managing dense cataracts in elderly patients can be challenging, but with the right planning and techniques, safe and effective outcomes are indeed possible.